Tuberculosis, a lot of times it's called TB. What is it? How do we get it? How do we diagnose it? How do we treat it? These are questions, hopefully, that I'll answer you. It's a disease caused by the bacterium Mycobacterium tuberculosis. The bacteria usually affect the lungs. For the most part, like 98% of it or something is in the lungs. So the TB bacterium was called Mycobacterium because it grows slowly like a fungus. If you have taken medical terminology, you know that myco means fungal, right? So it's like fungus-like bacterium, so it's called Mycobacterium tuberculosis. So this is a very slow-growing bacteria, and it has a protective layer. I think of it as a waxy coating over the bacteria. It's spread through the air from one person to another. Person has it in their lungs. The irritation in the lungs causes the infected person to cough. Right? This cough ejects the bacterium into the air. TB bacterium is small and light enough that it will float around in the air. This makes them an airborne isolation precaution as opposed to being a droplet isolation precaution, which most respiratory pathogens are droplet precautions. And what that means is if it's airborne, it's light, small enough that it floats around in the air, like a virus that doesn't have a cell membrane or anything. It has to remain within a small, or within a droplet of water to carry it. And that water weighs enough that about 6 feet away, you should be safe because it will have fallen to the ground, hit the ground before that point. But anyway, the person coughs, and the TB floating around can enter the lungs of anybody who enters the room. You walk in the room, you don't have protection on, you can inhale this tuberculosis. And the big thing is, if you have protection on, just a regular mask probably won't do it. It's not safe enough because the tuberculosis is light and it floats, and when you inhale, it can pull it around the mask. So you need one that seals, and that's an N95 mask. So it'll take an N95 mask if your patient has tuberculosis. And also they'll have to be in a negative pressure room. That means that you will have fan blowing air out of the room, usually up in the ceiling, and there will be a HEPA filter in there which will pull any of the tuberculosis bacteria out and trap it in the filter. And creating that negative pressure, what it does is it pulls air into the room. So any little cracks in the room, like under the door or something, air will be being pulled in there rather than these little floaties going and floating out. Air is constantly being pulled in and up through the filter. So when you open the door, if that negative pressure room is working right, you should feel a little bit of a pull on that door as the door wants to slam shut. And so that's a negative pressure room. That way, when you open the door, even with air rushing into the room instead of out of the room, it won't carry these bacteria out into the hallway. First line of defense in the lungs are macrophages. Macrophages will phagocytize the bacteria. That means they'll eat them, right? They'll engulf them. So they see the bacteria and they grab them and engulf them. So now they've got them inside them. Unfortunately, this waxy coating that I talked about on the tuberculosis bacteria protects it. So it can engulf it, but it's not very good. The enzymes inside the macrophage are not very good at breaking it up. They might kill it, but they won't be able to bust it all up like they normally do. Normally they break it all up and they take a piece of it and present it to other cells in the nearest lymph node. So if they succeed in killing it, it's still inside them. So you end up with a lot of dead macrophages with dead bacteria in them. They cause inflammation, symptoms of bronchitis. With this bronchitis, right, that's an itis means inflammation. So you've got inflammation down here in the lungs, and the end result of inflammation is it tries to wall something off, right? If it's a cut on your skin, it creates a scar. If it's somewhere inside, it will try to wall that infected area or the affected area off so that it doesn't affect the entire system. And these little walled off nodules, they're called granulomas or tuberculomas. If they get big enough, and I don't know what size it takes, but they get to a certain size, they call them gone focus. Not that it matters, but that's what they call them. An important thing to realize is that some of these macrophages travel to the nearest lymph node, right? They've got this bacteria in them, they travel to the nearest lymph node, and they end up activating the appropriate T lymphocytes. Now you've got these T lymphocytes out there cloning and cloning and cloning and creating effector cells and memory cells so that you hopefully will create an immune response to the tuberculosis bacteria. So they will patrol the blood and they will go there and they can get into these granulomas and help try to fight it and keep these things under control. And the person can spend, if there are any live bacteria in these granulomas, the person can, so that just tells me I need to make sure that you understand something, that in these granulomas that are full of macrophages, that are full of tuberculosis bacteria, those tuberculosis bacteria might all be dead. Some of them might be alive. They might have a whole lot of alive ones in there. But either way, it's going to look like a granuloma when we see it, right? When we do our x-rays and do our exams, all we're going to know is that they have these granulomas. And even if we do a culture and sensitivity on a sputum, we're not going to see it because it's not out in the sputum. It's all kept inside, packaged neatly inside this little granuloma. Or tuberculoma, that's probably a better thing to call it because you know exactly what I'm talking about when I say tuberculoma. Now if the tuberculosis if the person gets infected and the tuberculosis can reproduce faster than the immune system can respond to this, the person has an active TB infection. The infection spreads through the lungs, it can spill over into the blood, it can go and affect the brain, it can affect the kidneys, it can affect all of that. That doesn't happen to most people. Most people end up containing it in these nodules. I'll just be clear, when I say nodules, I'm talking about the granulomas. When I say tuberculomas, I'm talking about the granulomas, right? I'm using all three of those together, right? So that I don't want you to get confused on that, my terminology. I just kind of say whatever pops in my head. So now if the person may have gotten a little cough or something, but he ends up with these granulomas, doesn't even realize that he has TB, right? For some reason he gets a job that requires it, or for some reason he goes out and he gets one of those TB tests, right? So they poke him in the arm, right? Or they give that little needle there, the intradermal injection, which contains some TB proteins in it, and the person will react to that if they have these circulating T cells, right? They'll react to that. They'll get a type 1 reaction. I'm sorry, they'll get a type 4 reaction. So if they react to that, they say, okay, this guy has been exposed to tuberculosis because he has sensitized T4 cells. So since he has some of these lymphocytes, these T lymphocytes sensitized to TB, that means that he was exposed to TB, right? Otherwise you wouldn't have that. So now they're going to do a chest x-ray and they're going to look for these tuberculomas in there. They're going to look to see if they see these nodules. And the person will be treated, right? The person's going to end up being treated because, you know, I said that these tuberculomas, they may have nothing but dead tuberculosis in it. They might have some live tuberculosis, but we can't tell. The x-ray, all it sees is the tuberculoma or the granuloma or the nodule, whatever I happen to call it this time. So they'll see these in the x-ray, but they definitely will not be able to tell, is there live TB in there or is it all dead? Either way, if the person is asymptomatic, they know that it's contained, and the person is considered to have a latent TB infection. However, either way, if you have a latent TB infection, it's going to be assumed that you have live TB, and you will be treated. And we'll talk about the treatment in a minute. But you will have to be treated because we can't tell if you got any live TB in there or if there's not any live TB in there. But either way, you need to be treated because if there's some live TB in there, you can end up with a secondary infection. And what that is, it means that you had your primary infection, right? Your system walled it off. You might not even know that you got sick. Most people don't. They don't even know until they get that TB test and it comes up positive. It's like, oh, I didn't know. Well, then, so now they've done an X-ray and they can see these granulomas on there. And even if they don't see them, they're going to treat you because that just means that they're too small to see. But you were positive. Maybe a prudent thing to do would be to do the best test out there, that quantiferum gold, which is a blood test where they actually look for the sensitization in there. Because in the skin, sometimes a person might be reacting to the trauma of the thing, or they might not react because you might not have gotten a good enough injection in there. You might have gone too deep, got under the skin, and the person didn't do a good job. And there's also a little bit of leeway in the way a person interprets it. And I'll talk about that. You take this little wheel and you measure it, right? You measure the distance on that thing, and it's got to be 5, 10, or whatever millimeters. And so the way that you, or micrometers, I think it's called. But anyway, that interpretation, there's room for error in several steps of this skin test, whereas the quantiferum gold doesn't have all of that room for error. And that's why a lot of places that you work at require the quant gold rather than just the skin test. The person goes in, they've come up positive here, they went and got their x-ray, they see a granuloma. I'm just going to go down this case study thing here. They see the granuloma, and now the person is going to have to get treated. And the treatment is quite extensive, right? It's a pretty long duration of treatment. But before I talk about that, let's talk about when you have an active infection. You know that you have the infection because the people are very sick. And I'm going to talk about that just for a second here. The symptoms, they're going to have fever. Obviously, they got this bacterial infection. They're going to have fever. They're going to have chills and night sweats, body aches, weight loss. Right, so this is a lot of severe symptoms, and the respiratory symptoms they're going to have. They're going to have a cough for a long length of time. Now, if somebody has a cough for a week or even 2 weeks, but when you are coughing for a month, 2 months, something wrong. That shouldn't happen, right? So that would be one side, but it's also a progressive cough, right? It'll get worse and worse, and you end up with hemoptysis, right? That means that you're coughing up blood. So that's a definite sign. That's something that you want, that you're going to suspect TB on, and you're going to do the Mantoux test on that person. So, I mean, everybody with the symptoms of active TB, right? They have TB, they have the symptoms, so they have active TB. So everybody with active TB, treatment needs to be started immediately. However, everyone that needs to be treated is not necessarily going to be symptomatic. Now back to what we were talking about before. They have a positive here, but they don't have any symptoms. And what you're doing is you want to treat them so that they don't end up with a secondary infection. In other words, that granuloma breaks open, or your immune system can't keep the live TB that might be in the granuloma. They can't keep them in check anymore because something happened, right? You got HIV, or you're on chemo, or you got something weakening your immune system. So if TB does survive in the macrophages and it's walled off inside the granulomas, person can maybe never have symptoms, right? Can live his whole life like that and never have a problem. However, if the granuloma is broken open, or the immune system is weakened to the point that it cannot keep it in check anymore, then the infection spills out into the system, and the person suffers from this secondary infection. The problem is the person has a positive TB skin test, then the Gone complex is seen. It is impossible to know if the person has live or dead TB in that granuloma. For that reason, anyone that has had a TB infection will always be assumed to have TB on board. They're not infectious if they are not symptomatic. So if they're within that, they don't have it out in their sputum, right? They're not infectious, but we don't want them to end up with this secondary infection. So many of the people that have an infection, they don't know it. These people are in danger of developing what we call a secondary infection. The initial infection may have gone unnoticed until, for some reason, the person got a PPD or quantiferin gold, right? So just kind of wanted to review all that stuff. Now, as far as diagnosing TB, if they have active TB, you can do a sputum culture and sensitivity. It takes 4 to 8 weeks to get the results to that thing back, but you can definitely see the sensitivity part of it means that they're going to check it to see if this thing is resistant to some of the antibiotics that we use for TB. There is a thing they call expert. MTB, RIF, I don't know what all that stands for, but it's a test on the sputum and it can detect the TB. And it's not a normal culture that you have to grow in a lab, but they can detect the TB and they can tell if they are rifampin resistant. And rifampin is the first drug of choice for treating TB. It's an antibiotic specifically for treating TB. But that's all beside the point. If you are in my class, that's not what I want you to know. What I want you to know is the Mantoux PPD test, right? You have to understand what that is. That's a test that they give intradermally, and the person, if they have the circulating immunity to it, it will show up there, right? Your T4s have been now the Mantoux, that's spelled Mantous. It's also called PPD. It stands for Purified Protein Derivative, PPD, and TST, which is the one I like because tuberculin skin test. Right? That's what I like to call it. It's easy and it does exactly what it is. Now to administer this test, it's given intradermally, like I said, and these TB proteins are in it, and it's just 0.1 mLs. So you take a little tuberculin syringe. That's why they call them tuberculin syringes. They are 1 ml syringes, and they call them that because it's the main reason that you use one of those little tiny syringes is because you're giving this PPD test. So on that syringe, it's just 1/10 of 1 ml. That'd be very hard to draw up in your normal, 3 ml syringes or something like that. But it's very doable in a tuberculin syringe or a 1 ml syringe. And it's administered intradermally, usually in the forearm, right? You'll kind of mid shaft here in the forearm. You will do that. And when you inject it into the skin, it has to be intradermal, within that top layer of skin. If you go under it, you won't get a wheal. And when I say by a wheal is it will puff up, right? And it should bump up a little bit after you give that, when you give that shot. And it stings a little bit when you get it. Everybody's gotten it. So when you give that, if it puffed up, you gave it right. You don't put a Band-Aid over it or anything. You just you just give the injection, and when it puffs up, then you gave it right. And then you have to wait 2 or 3 days because, like I said before, this is a type 4 reaction. It takes a couple of days for it to actually happen. The type 4 reaction is the same kind of reaction that poison ivy is, right? You get in the weeds and stuff. It's usually a couple days later when you actually suffer the consequences for it. So anyway, this reaction here will show up in a couple of days. So what you do is you measure that you measure the width of it, and usually have some kind of little instrument. Where I worked, we always had a little wheel, and you could take it and you just put it on there, measure the distance of it, and it just said positive or negative. And the way you do it is you measure the bump. If there is a little reaction bump, and they call it induration, that means thickening of the skin in that spot. Might even have a blister. If they have a blister, you call it positive. If they have the little bump there, you measure it. If it's 5 millimeters or greater of induration, that means the little bump is that big. Now, we're not talking about the redness. You might have a big red area around it, but that's not what you're measuring. You're measuring the bump. When you measure that, if you're measuring it on a person that's high risk, 5 millimeters or greater is considered positive. Medium risk and high risk, by the way, is people who have been in countries where there's a lot of it, or people who've been around it or exposed to it, right? If you're just doing healthcare workers, you're going to go with 10 millimeters. 10 millimeters of induration for a healthcare worker means that they are positive. And actually, for the general public, they go with 14 millimeters. I would, yeah. But anyway, that's what they do. Now, treatment. We've got to talk about treatment of this. There is an acronym to remember, and it's called RIPE, R-I-P-E. And RIPE, R stands for Rifampin. I stands for Isoniazid, which is called INH very often, but isoniazid. So R and I. And the P stands for pyrazinamide. So pyrazinamide, so we've got rifampin, isoniazid, pyrazinamide. And the E stands for ethambutol. So that's the four things. R-I-P-E, rifampin, isoniazid, pyrazinamide, and ethambutol. If the person has an active TB infection, they are started on all 4 antibiotics right away, right? Kept in isolation. They have to be on these antibiotics for 2 months. Then they can back off and keep them just on the rifampin and isoniazid, or INH, and for the next 4 months. So it's 6 months of antibiotics, and that usually will get rid of it. Then they'll do a chest x-ray and see if it's improved. If it has improved, and they can see that the only thing left now is some nodules, they'll probably stop the treatment. If not, if it looks like there's still some action going on, they will go ahead and continue treatment. So it's going to be at least 6 months of treatment. Now, the people that have latent infections, right? That's the guy that got the positive TB. Right, he went in there, or the positive PPD test, right? So he went in there, it came up positive. They look through the x-ray, he's got the nodules. They say, hey, we need to treat him, right? I was talking about him before. So this guy here, his treatment is a little bit different. So now, for the people with latent infections, INH, isoniazid, they use that for about a year on them. It takes a little bit for it to get inside those nodules and treat them, right? And they want to make sure that all of the bacteria that are inside there are dead bacteria, right? Then that way they don't have to worry about a secondary infection. And so it definitely reduces progression to an active secondary infection. Sometimes they'll use other combinations of those 4 drugs. For the most part, it's just INH for 1 year. If they use combinations, they can cut it down to 4 months, but they've found that it's not as effective. Some people actually end up with reinfections after that treatment, so they're kind of back to the INH for 1 year. And like I said, in treating TB, part of it is isolation, right? Active TB needs to be, the patients need to be isolated. When in the hospital, they're going to have a negative pressure room with a HEPA filter. Caregivers will use the N95 mask. They have immunizations for TB, but they're not real effective. They're called BCG vaccines. It's used to reduce the spread in areas where there's a lot of TB. The estimated protection rate is about 50%, so it's not real impressive on how much it protects you. Some communities with different strains of TB actually are 0%, doesn't even help. But then some are as high as 80%. But the average overall is about 50% of protection with it. So it's definitely not the answer. There are several vaccines out there being worked on right now. So if they ever get those going, maybe someday TB will be something that we don't have to worry so much about.